мы начинаем нашу совместную секцию с Вен Lymphatic University, с Лауэллом Кабником, нашим добрым другом. Вы знаете, он неоднократно был на Санкт-Петербургском венозном форуме, но и в этом году до последнего мы собирались. Но, к сожалению, новая форма ковида нас немножко остановила. Но он с нами, мы здесь, мы вместе, и вместе обсуждаем самые актуальные вопросы флебологии. Лауэлл, nice to meet you. We are here.
Thank you for that wonderful invitation.
Today
I do
is,
hope
today
next
is this,
year that I will be back in St. Petersburg, embracing my colleagues, a wonderful city, and lovely people. Thank you for the opportunity.
We have a real Christmas meeting because very cold in St. Petersburg, very cold. Yesterday was minus 15, 17 Celsius. And today warmer, minus 10.
I'm sorry to hear that. I am in Florida and it is 78 degrees or 20 Celsius.
I was in Istanbul, it was 18, here minus 18. In one day, big change.
Lowell, we open our section, the section St. Petersburg Venous Forum and Vene Lymphatic University, and 2 words from your side and from Kурсат. We start.
On behalf of Vene Lymphatic University, a non-profit organization that furthers education to our colleagues to improve patient outcome throughout the world, we have over 2,000 members, and we will be going to do humanitarian missions to underserved areas, as well as educate our colleagues and our patients. So thank you on behalf of Vene Lymphatic University for the opportunity to have a joint program with the St. Petersburg Venous Forum.
It's also my great honor to be here in St. Petersburg. Lovely city, lovely friend, lovely atmosphere. And I'm sure it's going to be a great scientific activity during St. Petersburg meeting. Okay, sir.
Lowell, the first presentation, Alan Davis from Imperial College, United Kingdom.
Yes, he's having trouble right now with his computer online. So if you would skip him and move to the next, I am in contact with him now. Thank you.
Okay, and the next presentation is your presentation.
Here, I have no conflicts of interest with this talk. Early adopters noticed that there was a unique complication with thermal ablation, thrombus extension into the deep system. The company Venus Medical was keeping a registry of which we mined and reported in 2002 286 limbs with a 1% incidence of thrombus extension. In 2004, Anil Hingorani and Enrico Ачер at the American Venous Forum cautioned all of us by reporting their early experience. 73 limbs with a 16% DVT rate. In 2006, I presented at the American Venous Forum the classification and definition of EHIT. After analyzing many cases from 3 different institutions, it was certain that there were different patterns of extension. EHIT 1, venous thrombosis to the superficial deep junction, the saphenofemoral or the saphenopopliteal junction, not extending into the deep system. EHIT 2, into the deep venous system, non-occlusive thrombus with a cross-sectional diameter of less than 50%. EHIT 3, into the deep venous system, non-occlusive thrombus, cross-sectional diameter of greater than 50%. In EHIT 4, total occlusion of the involved vein. With regard to EHIT treatment, all of us have our own thoughts. Thus, it was clear to the American Venous Forum that there was need to develop practice EHIT guidelines. And as you can see in this diagram, there are many different ways and many different algorithms to treat. The American Venous Forum Guidelines Committee organized an EHIT writing group to analyze available literature regarding EHIT, to gauge the quality of clinical evidence, and to provide guidance on EHIT's diagnosis and treatment. These guidelines were approved by both the American Venous Forum and the Society for Vascular Surgery and accepted for publication JVS VNL in the Journal of Phlebology in January of 2021. Regarding methodology, there were 4 subgroups tasked to accomplish the following. 1, establish EHIT definition. 2, to discuss the available EHIT classification systems. And 3, evaluate prevention strategies and its risk factors. 4, appraise treatment options. We utilized 4 scientific repositories to identify potential publications related to EHIT: PubMed, Embase, Cochrane, and Web of Sciences. In addition, the following search terms were utilized: EHIT in patients undergoing radiofrequency ablation or laser venous ablation, DVT, SVT, which is a superficial venous thrombophlebitis prior to 2006, truncal veins, great saphenous vein, small saphenous vein, accessory saphenous veins, perforating veins were excluded. No restriction regarding language or research design. The grade system was utilized. We looked at both Kavnik and Lawrence classification and were able to translate the data as the descriptors are quite similar. Thus, the American Venous Forum updated the EHIT classification by essentially changing the Kavnik classification and adding to EHIT 1. If you notice over on the screen, the areas that are yellow, we added peripheral to the epigastric junction and central to the superficial epigastric vein and up to including the deep vein junction. So now let's talk about EHIT guidelines. There are 15 guidelines with regards to EHIT. With the time limitation for this talk, I've selected some, but not all. So let's start off with guideline 2.1, risk factors for EHIT. Some possible but inconsistent predictors or risk factors for EHIT includes large great saphenous vein diameter, previous history of venous thromboembolic disease, and male sex. These may be considered in pre-procedural phase, but the evidence is inconsistent through many papers. Grade 2C. Guideline 2.2, prevention of EHIT with chemical prophylaxis. The use of chemical prophylaxis for prevention of EHIT should be tailored to the patient after an assessment of the risks, benefits, and alternatives. Grade 2C. Guideline 2.4, prevention of EHIT by increasing ablation distance. There is a trend toward decreased EHIT when ablation is initiated greater than 2.5 centimeters from the saphenofemoral or saphenopopliteal junction. Grade 2C. guideline 2.4, prevention of EHIT by increasing the distance, has been shown in other new papers to be controversial. There are colleagues now that are starting at ground zero and showing that they have a decreased EHIT. So that's an upgrade that may change our guideline in the future, depending upon the laser fiber that people are using. So we'll pay attention to that future change. Guideline 3.2, treatment for EHIT1. Just as you would think, we suggest no treatment or surveillance. Grade 2C. Guideline 3.3, treatment for EHIT2. In the United States, we suggest no further treatment of EHIT2, but with weekly surveillance until resolution thrombus retraction. Grade 2C. However, as an alternative for EHIT2, consideration may be given for antiplatelet therapy or anticoagulation for EHIT2, weekly surveillance with cessation of treatment following thrombus retraction to the saphofemoral junction, grade 2C. Many of us are not treating EHIT2 in the United States, and many of us are not getting postoperative within a week duplex ultrasound to check for EHIT or efficacy, because what matters to us are patient symptoms. Guideline 3.4, treatment for EHIT3. We suggest treatment with anticoagulation for EHIT3, weekly surveillance, and cessation of treatment following thrombus retraction to the saphofemoral junction, grade 1B. And finally, ladies and gentlemen, guideline 3.5, treatment for EHIT4. We suggest the treatment should be individualized considering the patient risk factors, bleeding risk, and reference may be made to the chest guidelines for the treatment of a provoked VTE, grade 1A. Thank you, ladies and gentlemen, for the opportunity to present to this prestigious organization and the kind invitation by Evgeny Shedikov.
Dr. Kabnik, thanks a lot for this wonderful presentation. Now we have Dennis Borsuk for discussion. Dennis, you are there. Please, your comments, please.
Hello. Okay. Thank you for this brilliant presentation, for this work, the first guidelines about endovenous heat-induced thrombosis. So my question will be, nowadays, a lot of doctors propose not to do ultrasound examination after endovenous thermal ablations because cases of pulmonary embolisms, also massive pulmonary embolisms, are very rare. On another hand, today all of EHIT were treated by anticoagulation or at least anti-plaquette therapy. So we do not have understanding what percentage of massive pulmonary embolism would be if we were not treat this endothermal heat thrombosis. What is your opinion? Is it ethical not to do ultrasound examination after when we do not have what the percentage of massive pulmonary embolism would be without treatment of endovenous heat-induced thrombosis? Thank you.
Thank you very much, Dennis. It's always nice to see you. It's nice to also collaborate on EHIT in terms of things. And I was expecting you to ask me the question about the length of EHIT, but thank you for the easy question. The answer to you is that the incidence of pulmonary embolism is 0.001%. The analysis of of post-operative ultrasound and the cost of doing post-operative ultrasound to check for EHIT is very expensive because the risk is very small of going to a pulmonary embolism. And we know the biological behavior of an EHIT is different than a spontaneous DVT. So some of us have opted not to obtain a post-operative duplex. Some of us have gone to 30 days, some of us have gone to 3 months, and we know that the majority of EHITs, at least thermal, disappear within 14 to 21 days. The chances of looking for post-operative failure in terms of efficacy, in other words, when we go to ablate a vein, is also not tracked anymore because 97% or 98% of the time, the patient's ablation at 1 week will be perfect. So the reason for not getting a post-operative ultrasound is the risk of EHIT2 is rare and the efficacy is high. Regardless, it's all about patient symptoms. So that's another reason that we don't look at 1 week unless somebody has extending symptoms. Thank you for your question. I appreciate it. And hopefully that was a simple answer, but long-winded.
Lowell, what's your prophylactic policy for endovenous ablation procedures? Do you do anticoagulation routinely? What's your policy?
So somebody that has a high risk, and to give you an example of Caprini score, 8 or greater, we would prophylax, and I prophylax for at least 7 days. And we used to use low molecular weight heparin, but now we're using DOAC prophylaxis.
Thank you. Thank you, Lowell, for this contribution for this meeting.
Duplex ultrasound for terminal and pre-terminal valves and implications for CHIVA treatment. Yevgeny, thank you for this topic and the invitation to participate in Petersburg, even not being there, like I was 4 years ago where these photos were made. The most important point to investigate is the saphenofemoral junction, which is composed by the common femoral vein, the great saphenous vein, the groin tributaries, and the artery next. We have terminal valves and pre-terminal valves in the great saphenous vein. We have deep vein valves, and we have cranial and medial groin tributaries. The flow in the saphenofemoral junction in the healthy person is from tributaries to saphenous vein and from saphenous vein to the deep vein. This means from the net 3 tributaries to the net 2 interfascial veins to the deep veins. And we have to be aware that the tributaries in the groin flow downwards, but this is anterograde because they drain the lower abdominal party and drain into the great saphenous vein and then in the deep vein. We have different flow provocation maneuvers. One is Valsalva, everybody knows it, which is be refined as the Cremona maneuver. You use a folded straw and the people should blow inside, and this is easier to perform than the Valsalva. We have the classical manual compression, decompression of the calf, the toe elevation maneuver. We have dependency weight transfer maneuvers. And one very important maneuver is the dependency maneuver. Sometimes you have obvious reflux in saphenous vein. You have tributaries, but when you look at it, you don't see a flow. And in this case, you lay the person down 20 seconds with the leg up, and then you're invited to get up again, and you will have a long-lasting filling flow. This is seldom, but sometimes it helps to sort out if there is really a reflux or not. This is the same vein, standing position, manual compression, decompression after standing off 10 minutes. And this is just after dependency maneuver. Very important if you don't find out the thing you want. So now let's come back to the flow in the saphenofemoral junction, where you can apply all of those provocation maneuvers, and you should use at least 2 to be sure. If there is a reflux in the great saphenous vein, we have to find out exactly where it comes from. It can come from a tributary at the thigh, it can come through a perforator at the thigh, but if it comes from the groin, we have to differentiate. So it can be axial. This means it comes from the deep vein through the terminal and preterminal valve and go inside the great saphenous vein. This is called shunt type 1 or 3 in CHIVA, and it is 60% of the patients that come to a surgical office to be treated, like Solman investigated. Here you see the classical image. In the systole, you push up the blood, you elevate the toes or you compress the calf. And in diastole, you have a clear reflux from the deep vein through the terminal valve into the superficial vein. If you make a cross section, you have to put the probe immediately in the ostial level. This is here, this is the systole, this is the diastole. If you put a ring around the deep vein, you will have just the position of the probe there to be sure that you're testing the terminal valve. So this is the axial reflux, but then we have the situation that the terminal valve is competent and we have a reflux from one of the groin tributaries, which might be pelvic or epigastric origin. And this one is called paraostial reflux with competent terminal valve and incompetent preterminal valve. And this composes the shunt types 4 or 5 and happens in 20% of the patient. 1 of 5 patients coming to surgery, not with a little varicose, but to surgery, have this kind of option. So how do we see this? We have a systole where we see an anterograde flow. We have a diastole where we see a retrograde flow, but not from the deep vein, only from the tributary. Another image. This is the tributary, great saphenous vein, common femoral vein, systole with evident flow to the deep vein, diastole with a flow from the tributary, not from the deep vein. And if we look at it in the cross section, here again we see the deep vein, and here we see the reflux source. There is no reflux from the deep vein. So what do we do with this information in CHIVA? In the shunt type 5, we have a competent terminal valve. We have a reflux from a groin tributary, refluxing in the great saphenous vein. We have no perforating vein draining the great saphenous vein, and we have a tributary draining the reflux to a perforator more distal. This is the shunt type 5. What happens if we just deconnect the tributary? This is called CHIVA II, because at least the terminal valve is sufficient. And if we disconnect this one, there is no escape point below. And then the reflux from the groin tributary will drain into the deep vein, and there will be no longer a recirculation in the great saphenous vein. And this result happens in 97% of the patients with this situation. This was published by Zamboni. So if we have terminal valve competent reflux in great saphenous vein, we interrupt the tributary, we will have in 97% an anterograde healthy great saphenous vein. And this is 1 out of 5 patients scheduled for surgery, not those coming with little varicose veins where this is much more often to be found. In this kind of situation, sometimes it won't work. The reflux will still be in the saphenous vein and drain through another vein, through another new perforating vein opening or new tributary. So how can we imagine which one will work? It depends on the distance between the groin and the start of the tributary. If the tributary is at the thigh, the chance that it will work is higher. If the diameter of the great saphenous vein is little, the chance is also higher. The first intervention is always minimalistic. You have only a little cut, you have one only tributary dissection. What is a CHIVA option if you have an axial reflux, which is most often? If you have shunt type 1 or 3, this one is 1 because you have a draining perforator on the great saphenous vein, you will have to interrupt the saphenofemoral junction. When CHIVA was first published, we only knew surgery, and Franceschi published the interruption of the crosser of the ostial level of the saphenofemoral junction between the tributaries and the deep vein, so that the tributaries would wash out blood into the great saphenous vein and avoid a thrombosis of the saphenous vein. More modernly, you could make a short laser or a short endoluminal closure of the great saphenous vein distal to the preterminal valve, allowing a drainage of the tributaries of the groin to the deep vein. If you have this finding, like in this case with a perforator and a new secondary tributary, you should also interrupt the tributary at the level of the saphenous vein. So this was very important because the differentiation between the terminal and preterminal valve functioning changes a lot in the treatment if you apply CHIVA. If you have more interested information, you find one book about duplex ultrasound and one book of saphenous vein sparing strategies. And this is the moment to thank you for the invitation, for the attention, and I hope that we will meet next year in Hanover, where I'm the president of the German Congress, which will be also international. Take care.
You say a lot of some small veins in vena saphena magna. And,
okay, I understand.
Very important you say about.
Okay, I understand the question.
I think it's very interesting for me,
Thank you.
especially.
The horizontal reflux means, or the reflux, the paraosteal reflux, we didn't see it when we used to do radiology, because the contrast medium didn't go through these pathways. But since we have ultrasound, we first learned to analyze everything, and then just 10 years or 20 years ago, we learned that sometimes the terminal valve is competent, and it is the tributaries that drain. And I always, a little bit provocantly, say that people doing, for example, stripping or doing laser of the complete vein, they don't have to analyze this, because it is the same for the result. It is just the CHIVA group. In the in the CHIVA group, this difference was very relevant, and perhaps this is why we started this analysis. But if you have in mind this option, the possibility of having a terminal valve competent and a reflux from this horizontal tributaries, then you will find it. It is in 1 or 5 patients. It is not so seldom. And if you once have seen it, it is like oh, now I see it every day. I hope this is the answer to the question.
Erika, thanks for the contribution.
Hi Erika.
Hi.
And hi, Evgeny, Kursat, Lowell, and Luigi, and all my friends out there. Erika, I have whether it's a comment or a question, which is the commonest way of interrupting this connection right now? And is there any minimally invasive way of interrupting this connection?
The most minimally way to interrupt it, if you look at the vein, I think is the surgery, because you have to cut the skin, but you only put one clip around the vein at the ostial level. So considering the vein, the least invasive method is the first described by Franceschi. But considering the patient, and to my consideration, to close 5 to 7 centimeters with the endoluminal heat device, for example, is less invasive if you look at the whole of it. You don't have to cut the patient. But you are destroying 5 centimeters, and on the other hand, you would only destroy 3 millimeters. So we are working on getting it less invasive.
I guessed that this is happening and this is developing, and that is why my question, because I think thermal endoablation or some sort of chemical endoablation will become more and more refined as time goes by.
Yes.
Thank you. Thank you very much, Erika.
Thank you.
Спасибо большое, Эрика. Спасибо еще раз за прекрасную презентацию. Малай, Владимир, спасибо за вопросы, которые вы задали, и за ту дискуссию, которую развернули. Спасибо еще раз. Уважаемые коллеги, я хочу предоставить следующее слово Курсату Бозкурту. Значит, он у нас очно присутствует. Он ассоциированный флеботромбозом. Мы сегодня уже, вчера, вернее, эту тему поднимали, но вот сейчас взгляд Курсата Бозкурта. Антикоагулянтная терапия. Please, Курсат.
Thanks again. I start to feel myself Russian. The reason is we had a national meeting a couple of days ago. I didn't have such a presentations, moderating sessions in my meeting, although I'm the president of the society. Anyhow, the next subject I'm talking about is treatment of cancer-associated acute deep vein thrombosis. Recently, we published our guideline, our national guideline for the cancer-associated thrombosis, and I'm the principal author of this guideline. It's not going to be boring, but I'm going to give you some important data regarding that one. First of all, we should start from the beginning. Definitely, we should have ultrasonography, and we don't need any other tool for the diagnosis of DVT. The other complex techniques are not necessary for initial screening of these patients. Ultrasonography and D-dimer D-dimer might be used for the follow-up of the patient. It's very important. We should treat the patients at home as much as possible. There are several things we should consider. For example, if the leg is very swollen, if there's a possibility of emboli and other things, yes, this patient needs hospitalization. But otherwise, we like to treat DVT patients at home as much as possible, although there are some smaller risks here. If we talk about cancer patients, specifically cancer patients, there's a big increase of the deep vein thrombosis on cancer patients. There are several factors for it, and it can be tumor-related. Some cancers, like pancreas cancer, do have tendency to develop a deep vein thrombosis. Patient-related factors and treatment-related factors are all important for the occurrence of deep vein thrombosis for cancer patients. There is a very important question here. 10 to 15% of the patients who developed deep vein thrombosis might have underlying cancer. And if it's an unprovoked DVT, the possibility is high. Should we screen all of those patients very largely? No, it's not cost effective. We may do some prostate analysis for breast analysis for women and men, but definitely you cannot send all of the patients to PET CT to look at for cancer, so it's not cost effective. Until now, we used to use mostly low molecular weight heparins for the treatment of cancer-associated VTE. But vitamin K antagonists are not suitable stuff here. They do have higher VTE risk, and they do have 2.3 times higher blade increase. That's why low molecular weight heparins was standard treatment. The disadvantage is injection, and only 61% of the patients are continuing with oral anticoagulants, and only 37%. That means if you are prescribed low molecular weight heparins, you should know 1/3 never ever get, 2/3 never ever get the treatment because the patient doesn't like injection. It's normal. And in the initial DOAC studies, actually these initial DOAC studies do not concentrate to the cancer patients, but in those groups in those groups, there are a lot of patients with cancer, around 600 patients in those phase 3 studies for cancer. And what it has been shown that even in those cancer patients, the drugs are working nicely. Then specific cancer-specific studies were carried out, but they did one mistake. It was the competing was always deltaparin, but they reduced the dose of deltaparin, but they did not reduce the dose of drugs. So it is some sort of bias. That's why in some studies, the usage of drugs in GI, gastrointestinal tumors, was associated with high increase of bleeding. That's why there was a reluctance for it. There are some studies in that I don't have enough time to discuss, but these are well-designed, really big studies. For example, Caravaggio, Pfizer study, ADAMET study, and SELECT-D study for rivaroxaban organized by Bayer. They are very nice studies. And these studies represent all of the cancers we do see in our routine life, colorectal cancers, lung cancers, and everything. So these are the results of the studies. Again, I don't have enough time to discuss all of them. But what we can see here in this study, yes, they do work well in cancer patients as well, drugs. They do not increase the bleeding except luminal GI cancers. So these studies, these important studies, did show the role of drugs in the cancer-associated thrombosis. This is our guideline. This is normal patients, normal DVT patients, not cancer-associated. As you can see, we do suggest very strongly drugs for normal patients. Regarding the European Society of Vascular Surgery and American Society of Hematology, they do also suggest drugs for cancer patients, but there's one difference. European Society of Vascular Surgery is a conservative group. They still consider low molecular weight appearance priority, but in American Society of Hematology guideline, the drugs are in front. The reason is, I mean, this ESVS is quite conservative treatment. And very important slide. This is our recommendation, our national guideline. In case of VTA, we do suggest drugs for the treatment. It is 1A recommendation. It might be apixaban, they have data. It might be edoxaban, they have data. And it might be rivaroxaban. Dabigatran doesn't have cancer-specific data. One important detail here. In case of GI cancers, you may prefer apixaban, the others, because the data is interesting here. Recently, only 6 days ago, ACCP published the new guideline, and in this guideline also, in GI tumors, specifically luminal GI tumors, ACCP also suggests apixaban more than rivaroxaban and edoxaban. Sorry, what's going on? My slides had a problem. Anyhow, regarding the catheter-directed thrombolysis in cancer patients, we do. If the patient has iliac iliofemoral DVT and the age of the thrombus is young, below 2-3 weeks, we do like to use catheter-directed thrombolytic therapy. There are new generation devices like Angiojet Zylanta, Clot Retriever by Inari, Asprex, Indigo, Penumbra, and Aspiremax. These devices are more efficient than the previous devices. Maybe you may remember Attract trial and Kava trial did not show any superiority for it, but new generation devices might be quite helpful. And in some patients, we really do catheter-directed thrombolytic therapy for cancer patients as well. Thanks again.
Спасибо большое. Курсат, пожалуйста, у нас дискутант Алексей Фокин из Челябинска. Алексей Анатольевич, сейчас, минуточку.
Thank you very much for high-level presentation. My question is, you are ready? Anticoagulation therapy for children with active malignancy. Your opinion, guidelines, and real clinical practice in Turkey.
There is only one data which is with rivaroxaban, not cancer patients, not cancer children. There is one data, rivaroxaban can be used on those patients, but I'm not aware any data for cancer and children with using DOACs. So I believe in these patients still gold standard might be low molecular weight heparins because we don't have enough data for it.
Thanks.
Спасибо большое, Курсат, еще раз за прекрасную лекцию. Алексей Анатольевич, спасибо за вопрос. Значит, мы переходим к следующему докладу. У нас в сети появился Алан Дэвис из Лондона, из Великобритании. Алан, пожалуйста, я бы перевел его, название его доклада так, по-русски. В конце концов, как же мы лечим эти венозные трофические язвы? Алан, please. Нет, это Виктор Каната у нас.
Good morning, everybody else from
Хорошо.
Paraguay to St. Petersburg, Russia. This is Dr. Victor Kanata from Paraguay. I'm part of the VLU, a new kind of broadcasting platform who will teach and give new resources for the physicians, students, and all patients, trying to embrace them and give a better results and better outcome in patients with problems with veins and lymphatic disease. I will talk right now to CLACS, cryolaser and cryosclerotherapy with polidocanol. I would like to say thanks to Dr. Lowell Kegnick, who is the chairman of the VLU, as well as Dr. Evgeny Shardakov, that is the chairman of the St. Petersburg Vein Forum. I would like to say thanks to all my friends in Russia who are listening right now to the Vein and Lymphatic University Forum that we have in St. Petersburg right now. I don't have complete interest. CLACS is the acronym of cryolaser and cryosclerotherapy, and together show us new path for this kind of new treatment. The laser treatment is done on the frozen air. We help with the patient with the pain as well as improving the effect of the laser. The CLACS technique works with 50% glycol, 75% glycol, or polidocanol 0.25%. I use an ND Yak laser 1064, a vein viewer, and the Fredo frozen. And I think from my point of view that we have to just remember something. All the veins, they have to have a leaking point as well as the feeder vein. If you find the feeder vein, you will be able to fix the trouble and fix the problem of the patient, and you will have very good results. Check this video, show how I've been working. This is the Freedom machine. This is the laser. Give a small shot of laser. Then at the end of you see there's a little bit of shrinking of the vein. We give the final shot of polidocanol 0.25%. Always with the frozen Frido will help us just to improve the way that I'm working both treatments, the laser and the sclerotherapy. The transdermal laser has the ability to do a selective photothermolysis and penetrate the skin without damaging it and closing the vein. You see, you don't give too much, you just get near to the skin, use the Frido, and you shut the vein just a little bit, just to shrink the vein a little bit, not too much, to harm them, to give a burn or just put in trouble your treatment. Then you have to give your treatment with the polidocanol 0.25%. You can see here and again we found the feeder vein. After we found the feeder vein, we checked one time and again, we moved it again, and then we saw the result. We saw that there is some shrinking of the vein, and then we applied the polydocanol 0.25% inside of the vein. We made the vein disappear. The partial injury of the intimal media is done by the transdermal laser, and the osmolar injury is caused by D75 as well as the polydocanol that we are doing here in Paraguay. The results are very good, and the people and the patient love it. This is the histological picture showing that the thermolation gives destruction and edema of the internal diameter, and the vein gets smaller. And then you will see with the 0.25% polydocanol that the vein is already closed with less clot and less hydropigmentation. What are the technical requirements that you have? You need to have flavor suite, you have to have all the machine, augmented reality, laser NTR 1064, the Fredo frozen machine, and your scleral agent that you will choose. You have to know about anatomy, physiology, pathophysiology, your tools to recognize what you have, history and physical, and Doppler ultrasound. Photo documentation is the key for this kind of treatment. I usually use like shooting more than 50 pictures for each patient, going up and down, right leg, left leg, and store them in two different ways. First in an iPad, and then in a large storage place when I will be able to see the result and show the patient that the patient is improving after the treatment. And this is a new kind of variation that we use, trying to find out where are complex veins and just only the telangiectatic vein. The complex vein has a number that we call the number 9, as per Dr. Katsuo Miyake, because they have feeder veins and they have a lot of complications, just a little bit difficult and different just to fix than the number 1. And we are moving forward from the number 1 to number 9, as well as the patient has more veins, more telangiectasis, and more feeder veins that we need to fix it. Feeder vein is usually the key for this treatment. You see how we found the feeder vein just with the vein viewer. You look where is the flow of the vein coming, and this is the place that you have to shoot the laser to make sure that the patient is okay, and the vein will shrink it, and then you will give the polydocanol 20.5%. Let's give you a short resume. Augmented reality visualization of the feeder vein is the first thing that you have to do. Then you do a laser, then you do your sclerosal agent polydocanol, and you always process the skin with the Fredo. This is the picture. In the first one, you will see the vein, you find the feeder vein. In the second one, you shot the laser. And the third one, you see how it collapses. And in the fourth one, you give the polydocanol 0.25%. You will have very good result. It's at the same 0.25, 75% glycose that Dr. Katsuo Miyake used. Those are two the same treatment. What are the laser settings? Everybody wants to know about it. 16 millimeters spot size, 70 joules, fluency up 15 the pulse width. As you can see over here, you see how do we shot the laser, and in the other one, we keep just giving some frozen air with the Fredo, making sure that the vein shrink, just to expose and unveil the endothelial layer, just to give in the second shot the polydocanol as a foam or the 75% glucose. You can see this is the way that I've been working. I just give 2 or 3 sets of laser shots. Then I've been using right now the polydocanol as a foam 0.25%. Look how it disappeared immediately after the treatment. You don't give too much, just give a little bit, and then you will see the result immediately. And the other one is 0.25% of glycose, 75. I use a little bit more just to fill the full vein when you use glycose just a little bit different than when you use polydocanol. When you use polydocanol, you just use a little bit polydocanol in each shot. And when you use glycol, you have to give large shot, like a 1 cc each one, to make sure that all the veins filled with polydocanol. All the veins are already treated, and the results are very good. What are the periods for the young one? Laser settings 46 millimeter, fluence of 60 to 70 joules, pulse white 10 to 15. Freedom is the key. You have to froze the skin to the patient. Don't feel the pain and be happy with the treatment. The cosmetic patients are always different than our regular patient. You have to tell them always the truth. Improvement of the patient are more than 80% after the surgery. The CT work and all the aesthetic patients have to be mastered. You have to be trained. You have to know the technique. You have to see the patient, show how it's working, and you have to learn about laser technology as well as sclerotherapy. The combination of those will have very good results. This is the first shot before laser and before sclero. This is the second shot after a little bit of laser. This is the third one after before the sclerotherapy, and this is the result after I finish the treatment. The results are excellent and the patient loves it. In the future, BLU will show a live session and will teach in the future to many of the people that we have around, trying to improve the expertise of the physician. And this is the final idea of Venus and Lymphatic University. We will develop courses, training and teaching in Zoom, live session, as well in person when we finish with the COVID session. Thank you very much for all your help and listening to me, and we will be waiting for future questions.
Victor,
thank you very much, and have a good day to everybody from Russia.
Victor, thanks for this wonderful presentation. We'd love to join for any activity for Wien and Lymphatic University. Believe us, we will be with you. Just let us know what we can do for the future of the trainees in philology. Now we have Dimitri. Dimitri, where are you for discussion? Long, tall Dimitri.
Can I speak Russian?
Yeah. I don't think you can speak Russian because Victor cannot understand. There's a problem. Please speak English.
What is the question? But the problem is like this. You are a young fellow, a young phlebology. You have to change the way that we are seeing everything. We are talking right now about aesthetic phlebology, and you have to develop your practice, trying to have the better outcome for your patient as well as for yourself. I usually, just to give you an idea, I book the patient 1 week to each other, and then every 15 days, I saw the patients very often to make sure that my results are good. And this is your final idea when you do your treatment. This is a new technique. You have to master it. You have to make some kind of changes. And the only way you will be able to fix it is you saw the patient often. Sometimes when I know that the patient is already in my schedule and is already my patient, I know how will be the session. And I book the patient every 15 or maybe 30 days. But the idea is just to follow through to have the best result for you.
Thank you so much, Victor.
Right, thank you, Dimitri. We have to move now. We are inviting Professor Alan Davies from Imperial College London. Professor Davies, are you ready?
I'm ready, and I apologize that you haven't got a video presentation, but until about half an hour ago, I hadn't had confirmation that I was talking at this meeting, hence my appearance as Santa Claus or St. Nicholas, whichever it is, because I've just been doing my outpatients. So my patients are missing out on Christmas celebrations. So it's a great pleasure to talk to you about venous leg ulcers and what are the appropriate... And the answer is they are all appropriate treatment options. We certainly know that if we look at the literature, what the guidelines tell us is that there are lots of different views as to what is the most appropriate way of treatment. There's a great degree of heterogeneity, and certainly internationally we could do with more clarity. We would all accept that those patients who present with a venous leg ulcer, their assessment should obviously be clinical. They need to have their ABPIs measured, and they need a duplex assessment. And that is the basic minimum. We should all know how to do an ABPI measurement, and providing the ABPI measurement is greater than 0.8, patients should be put immediately into compression in the community if the clinical diagnosis is one of venous leg ulceration. So if we start off with compression, we know that compression improves healing. We know that good compression works, poor compression doesn't. And we also know that compression has a role in preventing leg ulcer recurrence. We also know that a large number of studies on the role of compression hosiery have come from the United Kingdom, the whole series of the venous trial. We also know very well the ESCAR trial that showed that actually open surgery was not any better than compression with respect to getting healing, but was better with respect to long-term leg ulcer recurrence. So what are your potential options of a patient who presents with a leg ulcer? Well, I've already told you that we'd think about doing an ABPI and a duplex scan, but should the duplex just be the common femoral vein and below, or should it involve the whole of the venous tree, including the IVC and the iliacs? Then you've got another dilemma if we're thinking of intervention. Should we intervene on the superficial veins first, the iliac veins first, or do both simultaneously? Now, firstly, if we think about imaging of the iliac veins, and this is a practical solution, it's not the one that I would say is the gold standard, but it's probably, if you have got limited resources, is probably where you could go to, that you do not need to duplex the iliac veins if there is no history of a DVT, or if this is a primary ulcer. However, if the ulcer has failed to heal, then it is probably an indication to go on and image the iliacs. If, however, there is a clear history of a DVT, then I think it is imperative that the iliac veins are imaged, particularly by duplex. CT, MRV, and venography should be reserved for those people who you are pending and think you would perform an iliac intervention on. Certainly, I don't need to tell you that the benefit now of healing with respect to leg ulceration from the Everett trial, that it has easily been shown that leg ulcer healing can be improved. Leg ulcer recurrence can be reduced, and it's a cost-effective strategy, and that basically you want to eliminate superficial vein incompetence. So I would suggest to you all that we should have a good 2-week global pathway where a patient presents with a leg ulcer in the community. They go into compression immediately in the community. They are referred to a suitable institution for vascular intervention and vascular investigation and need to go into long-term compression. We can do 2 weeks in the cancer population. Why should we not be able to do this in the leg ulcer population? So where does iliac vein stenting? This is obviously a topical issue. It's inordinately expensive, but does keep some people gainfully employed. Well, if we look at the data from Neglen and Raju, where they did a combination of iliac vein treatment and superficial vein treatment, you can see that 32% of their leg ulcers did not heal. This is certainly worse than the results that you got from compression in the Everett trial. So it just to highlight that actually dealing with the iliacs and the superficial veins is not actually necessarily the panacea. If we look at a data in a study that we performed now some years ago, there really was very little evidence to suggest the benefit of relieving iliac vein obstruction on leg ulcer healing. One of the few studies that is actually out there that supports the role of iliac vein stenting in the leg ulcer population is a study by George and Tripathi from India, where in a group of patients whose leg ulcers had failed to heal after having adequate compression or superficial vein treatment, they did then intervene on some patients with iliac vein disease and showed improved leg ulcer healing. This is the only randomized control trial on chronic venous disease and iliac vein stenting, and this really did not have enough C6 patients to be able to come up with any comment. So again, no good evidence. So if we then move on to the favorite topic of many people, the perforator. We now have this concept of something called the pathological perforator as defined by the SVS and the AVF. But we're just revisiting history. It was very clearly shown by Van Gent many years ago in a randomized trial that the only people who benefited from perforator intervention, and these were medial perforators, were those patients who did not heal after they had previously had superficial vein ablation. So I would suggest to you that hunting the perforator may be a red herring, but there may be a very few patients that might benefit. So what about injections under the base of the ulcer with foam sclerotherapy? There's no good evidence. It's all very much expert opinion, but we all tend to do it because it makes logical sense and have seen some anecdotal evidence of some good results. We also know that you can treat the vein under the ulcer. If you've got a truncal vein, this can be done with something like the Claravane catheter. It could be done with glue or a catheter just with a sclerosant. But the nice thing of the Claravane catheter, you can put the foam under the base and then you can treat the rest of the vein with the sclerosant, and this can be done cannulating far away from any diseased skin. So one of the other issues is how do we implement the strategies that we want to get these patients their optimal treatment? Well, to just give you an idea, after the Everett trial, you can see that globally there is a delay in patients getting referred from the community to a definitive caregiver of around about 6 weeks. In the UK, it's 8 weeks. And I think this is something very important, that the key thing is that we need to educate those doctors and nurses working in the community that these patients need to be sent to a ulcer strokes vascular specialist much sooner than they tend to be at present. In the UK, this has led us to this following guideline, which basically is propagating the idea of a two-week pathway to get an early intervention performed. So I would suggest to you that early referral is key, early treatment is key to avoid ulcers becoming chronic. But what is important, we must not forget that these patients have significant issues with respect to maybe their physical health. We need to think about the other morbidities associated with leg ulceration and the impact on their psychology. And it is very important that when you are treating these patients, you think of them very much in the holistic round. So ladies and gentlemen, I would like to say that when you are treating a patient with a definitive venous leg ulcer, you should think of compression for all. The majority will need treatment of their truncal or incompetent superficial venous system, and iliac vein stenting should be considered, but only for the few. Thank you very much, and I wish you all a very good Christmas. Thank you very much.
Алан, спасибо огромное. Это действительно рождественский митинг. Christmas meeting in Санкт-Петербург. Один короткий вопрос из Санкт-Петербурга от Михаила Богомолова. Пожалуйста, Михаил.
Thank you very much, Dr. Davis. It is a real pleasure for me to meet you because I studied very carefully publication about your recent study comparison of early and deferred endovascular treatment of patients with ulcers, venous ulcers. But I am not convinced that your conclusion is correct because, first of all, ulcers which were included were not divided to groups of superficial and full thickness ulcers. They were studied together, and we know from our experience that all superficial ulcers could be successfully treated with compressive surgery during 2 months. But the time for healing of deep, full thickness ulcers depends on their original size. That's why you didn't perform difference, calculated different groups, results in different groups, and that's why the difference in the healing time, it was, as far as I remember, close to 10 days, 62 in the early operated and 73 in the later operated. This difference is not very significant as I see, but you find mathematically significance, it was reasonable, but it is not very convincing because different depths of ulcers dictates different period of healing. But my question is about position of you as a surgeon. Oncologists, general surgeons usually do not perform surgery until healing all wounds on the surface of people. But phlebologists insist that it is better to perform surgery before healing. What is your personal opinion about this position?
Well, the straightforward answer is until we did the Everett trial, I very much used to get patients to get their leg ulcers to heal, and you'll know that was slightly contrary to the AVF recommendation, which was a 2C recommendation to suggest superficial intervention, because we'd very much been influenced by the ESCAR trial results that showing that there was only benefit with respect to recurrence. I think if you look at the results of the Everett trial, it shows very conclusively that it is undoubtedly better to intervene on the superficial veins early. But I think I would also like to highlight to you that actually by the time we got to the veins, because of the issues with referral, they were actually intervened. Most of the ulcers had been present for at least 3 months, 3.2 months. So, but I think where we're actually all getting it wrong is that if we were to pick these ulcers, because at the end of the day, all ulcers start small and get bigger, unless you can show me some evidence differently, that these need to actually be treated by a specialist immediately to give you the best results, be it compression or surgical or endovenous intervention. But I think I'd also like to highlight to you that the results from the Everett trial were the results with compression were the best recorded results from compression healing that have ever been reported in the literature. So the fact that we were able to show that there was a even better outcome with surgical intervention, to me, really proves the point quite markedly.
Edun, thanks a lot. We don't want to keep you very well because you are very busy for Christmas greetings, Christmas organizations. Have a good day and a wonderful Christmas and greetings.
Thank you very much, and I'm sorry to leave you, but I've got to go back to do my outpatients. This is my swan song. Thank you very much, and I'm sorry I'm not there with you all in person.
Bye-bye. Bye-bye.
Уважаемые коллеги, мы приступаем к следующему докладу. Следующий доклад из Колумбии. Из Колумбии и Аргентины совместный доклад Хорхе Ола и Карлос Симкин.
Hi everybody, it's my pleasure to present to you when to use drugs and which ones, evidence-based on the context of chronic venous insufficiency. This presentation is made under my University de los Andes and my hospital, Fundación Santa Fe in Bogota, Colombia. First of all, I would like to thank Dr. Evgeny for the kind invitation in this 14th St. Petersburg Venous Forum, the most prestigious and beautiful Christmas meeting around the world. I have no conflict of interest. The context of this kind of disease, it shows the prevalence that has increased with age, and it's more common in female than in men. It costs to the health system around 2% of what they spend in any kind of diseases. We're going to focus on this presentation the pharmacological treatment, and the objective to treat a patient with any kind of inactive drug is to improve venous physiological function and to provide symptomatic relief and sign improvement. We have to take into consideration the scientific evidence that is out there, the patient preference, the experience that we have under that, and of course, the availability of the product that we have in our geographic area. The inactive drugs retard the progression of the disease, decrease the edema and venous symptoms. It is safe, avoidable, and widely available. And main adverse outcomes could be digest or headache in some points, but it's fairly rare. We have benzopyrones, flavonoids, saponines, plant extracts, and synthetic drugs out there. In our armamentarium, my preferred one is micronized purified flavonoid fraction. This is a flavonoid that has an increased viability due to the micronization process. The reduction of functional discomfort, the decrease in cramps, and even in edema, it's one of the main things that it focuses on. It says that it reduces the ankle and calf circumference. I have to take this very carefully, this data. But of course, the most important and the most relevant one is the improvement in quality of life. This is the one that I prefer due to the amount of evidence that is out there. We have a presentation of 500 milligrams or 1,000 milligrams. You can use 500 twice a day or 1,000 once a day. The evidence goes toward using monodose of 1,000 once a day, which is the same thing. The downside of this is that you need to treat the patient at least for 8 weeks in order to get to any measurable advance in the disease. Oxyrutinins is dose related. It has an inhibitory effect on microvascular permeability, has a good efficacy, compliance, and it has reported no side effects. Saponines such as asin is an anti-edema drug that creates an anti-inflammatory environment with some venotonic properties. It has a selective vascular permeabilization, enhances the venous contractility, and it improves the symptoms during the first week of treatment. It is very, very fast in the way it acts. Calcium dobesylate is the synthetic one. It targets the endothelium and basal membrane of capillaries. It is really unclear if it is working as good as a placebo effect. There is evidence out there that says that it could be associated with that. And it's associated with a granulocytosis, that it's something that it's very weird to happen, but it's something that it could be fatal. It creates significant improvement in night cramps and discomfort, and reduces pain and paresthesia and malleolar swelling. The natural compounds, we have Centella asiatica in our country, which creates a symptomatic relief in capillary filtration. It reduces the circulating endothelial number of cells, and it has an action in capillary wall and has no side effects being reported. From the natural compounds, red vine leaf extract has been also mentioned. You can find it in all your natural stores. And the conclusion, the quality of life scores are useful to choose management and assess response. It has diverse options. The treatment must be adjusted based on patient needs, and the treatment is aimed to cost effectiveness and availability for the patient. In my name and the name of my group, Spasiba.
Джордж, спасибо большое за интересную презентацию. Значит, у нас есть дискутант из Петрозаводска, Эрнест Щеглов. Пожалуйста, Эрнест.
Thank you very much for your presentation. I have such question. Sometimes I meet the patient who is so suffering from the huge vein symptoms that he says that he would like to use the vein-active drugs constantly, forever and ever. What do you think about the duration of treatment?
We have to take into account that there is an expense on that. So it depends if the patient is the one that is buying that, or the health system is the one that is providing them for that. In any case, I wouldn't recommend more than 3 months and then a break and then reassess to see if there is the need to prescribe it again. But at least 2 months to see the results. It's what the evidence shows, and at least 3 months in my case, that's going to be my recommendation.
Jorge, thanks for this wonderful presentation. Ernest, I have one simple answer to you. I'm living in a very hot climate. I mean, Turkey is a very hot country. What I'm doing is personally, if the weather is hot, I give venoactive drugs. If it's cold, keep only varicose stockings. It's the very simple solution. Okay, Evgeny?
Yeah.
Jörg, thank a lot for this contribution. Now we can move to other speaker, and it's Alexandra. Alexandra is online or from video?
Следующая презентация.
Can you see my presentation now?
Alexander Zhiyovaruchka.
Yeah.
Yeah, can you see me? Yeah, thank you. Thank you. So first of all, I would like to thank the organizers for the invitation. Of course, I would prefer definitely to be there with you, but unfortunately I couldn't. So the topic of my lecture is treatment of pelvic origin varicose veins. I don't have any potential conflict of interest to disclose. We all know that the pelvic venous incompetency may cause a different clinical presentation, and one of them are pelvic origin varicose veins, which may be atypical varicose veins, so non-saphenous distribution, vulvar varicose veins, or typical saphenous-tracheal incompetency and related varicosities. In many cases, it's both, so vulvar and lower limb varicose veins. So we have to keep it in mind when the patient comes to our office, because they usually do not mention about the vulvar varicose veins. How it's possible that we have lower limb varicose veins which are of pelvic origin? It is because of the connections between the veins of pelvis and the veins of the lower limb, which comes to the natural foramen. And we call them pelvic escape points. So here you can see where these pelvic escape points are located. The most common pelvic escape point is perineal escape point. It is responsible for 71% of pelvic origin varicose veins. It is caused because of the reflux in the internal pudendal vein, which exits the pelvis and has the connections with the posterior labial veins, vaginal vestibule veins, and dorsal clitorial veins. Hence, we have three perineal escape points: clitorial, intermediate labial, and the perineal escape point. This escape point may cause varicose veins in the thigh and also in the buttock. It is nicely visible in the ultrasonography, so we can find it during the transperineal ultrasonography. The second common escape point is an inguinal escape point. The reflux is transmitted through the round ligament vein and may cause the vulvar varicose veins with the groin swelling, and also thigh varicose veins, and it is also easily visible during the ultrasonography. The third escape point is the gluteal escape points. We have two gluteal escape points, superior and inferior, and you can also see it during the transperineal and ultrasonography at the buttock. We have to remember that in many cases there are several escape points, and the proper diagnostic and the treatment of all these escape points is the key to the success. So let's skip to the treatment of varicose veins of pelvic origin. According to the studies, among patients presenting with varicose veins of pelvic origin, less than 10% have been reported to have pelvic symptoms. So more than 90% of patients do not require any pelvic treatment at all. In that case, we can perform a local procedure, so sclerotherapy from below, ligation, or phlebectomy. How about the literature in this field? According to the Gavrilov studies, a consistent therapeutic and cosmetic effect was found in 83% of patients after sclerotherapy at 1 year follow-up, and there were no recurrences of vulvar varicosities in all patients after phlebectomy up to 8 years follow-up. Another study has shown that the surgical ligation of the leak points was associated with only 2.2% of recurrency. Another study has also shown that the improvement was noted in almost 80% of patients after sclerotherapy in the mean follow-up of 4 years. How about the pelvic vein embolization in pelvic origin varicose veins? There are only prospective studies, but the studies has shown that the mild or moderate improvement of varicose veins was found in only 51% of patients, and none of the patients had a significant improvement. Another study has shown that the lower limb varicose veins after coil embolization disappeared in only 14% of patients. Luckily, vulvar varicosities disappeared in 88% of patients. And another study has shown that 54% of patients had recurrency after their embolization at 3-year follow-up. So this treatment is not so good in that case. There will be new European Society of Vascular Surgery, so SVS guidelines. They will be published soon. They will be published in February, so you will have an opportunity to see it. And there will be a chapter about the pelvic origin varicose veins treatment, and there will be a recommendation. And according, I had lucky to be in a part of the writing committee. And according to these guidelines, in patients with varicose veins of pelvic origin without pelvic symptoms requiring treatment, local procedures for varicose veins and related pelvic escape point should be considered as initial therapeutic approach. And that pelvic vein embolization is in such patients as an initial treatment should not be performed, so a negative recommendation. Of course, in case of pelvic symptoms requiring treatment, pelvic vein embolization should be considered to reduce that symptoms. So what is my treatment approach? I usually perform sclerotherapy of pelvic escape points firstly, because they usually have winding course. But we have to remember that when we perform the sclerotherapy, we have to inject the foam deeply under the fascia. In the first film, you can see that I didn't inject it deeply, and it closed the related varicosities, but it didn't go to the pelvic escape points. So in the second time, I injected it deeper, and you can see that it closed the pelvic escape points, and it is fulfilled with the foam. I usually perform the sclerotherapy of perineal or all escaped points with the high percentage, usually with 3% STS foam, and related varicosities with 1% STS foam, and for reticular veins and telangiectasias 0.5% STS foam. And the results 6 months after the treatment, you can see at the photo. The similar case, patient with the perineal escaped points, the procedure was similar, and the results 3 months after the treatment are very good. We also have to remember that in some cases, the vulvar varicose veins and the lower limb varicose veins are associated with the external pudendal vein incompetency, which is a tributary of great saphenous vein or saphenofemoral junction. So in all cases, we have to perform a deep ultrasonography and evaluate the saphenofemoral junction at the great saphenous vein. And in that case, I also perform sclerotherapy using 3% STS foam for the external pudendal vein and for the related tributaries with 1% STS, and the results 12 months after the treatment are very good. When we perform the vulvar varicose vein sclerotherapy, first of all, we have to close the varicose veins which are lying deeper before we start closing the visible varicose veins. And all the procedures should be performed under ultrasound control. I usually use 1% STS foam for the vulvar varicose veins. And you can see the results of such approach are also very good. And when the pelvic escape point is bigger than 1 centimeter in diameter, we can perform a ligation and phlebectomy of the related varicosities. In very rare cases, vulvar varicose veins may be associated with the pudendal hypertrophy. And in that case, I performed firstly sclerotherapy of the varicose veins. And in the second stage, I performed labioplasty. And as you can see, I resected almost 1.4 kilogram of the tissue. Of course, pelvic vein incompetency may also cause scrotal varicose veins. They are usually connected with the reflux in the internal pudendal vein and then posterior scrotal veins, but may also be associated with the saphenofemoral junction or great saphenous vein incompetency and the reflux in the external pudendal vein. It may also be caused by the testicular vein reflux. It's sometimes associated with the angiokeratomal fordyce, which often spontaneously bleed. And in that case, sclerotherapy as the first treatment, and for angiokeratoma, I usually use transcutaneous laser. And I would like to show you the case of a very huge scrotal varicose veins, where the patient came to me because of the bleeding from these varicose veins. And he had two pelvic escaped points. One is perineal escaped points, and also he had incompetent deep external pudendal vein. So in first case, I performed the sclerotherapy of these escaped points under ultrasound control, and then the related varicosities using a 1% STS foam for bigger veins and 0.5% STS foam for smaller veins. And the results immediately after the treatment, 1 month after the treatment, and 6 months after the treatment without the visible varicose veins and without the varicose veins under ultrasound control. According to the studies, 3% of male have also varicose veins connected with the pelvic vein incompetency, which we also have to keep it in mind. And usually the reflux in the internal iliac veins, not testicular veins, is responsible for that varicosities. And in that case, treatment, local procedures, so sclerotherapy or mini phlebectomy, gives also a very good results. Here I performed sclerotherapy for those varicose veins, and the results 3 months after the treatment are very good. So in conclusions, we have to remember that varicose veins of pelvic origin are an interdisciplinary problem. Proper diagnostic and elimination of all pelvic escaped points is the key to the success. The minimally invasive procedures should be considered as a first-line treatment, and I would like to emphasize that. But of course, more studies are needed, especially randomized control trial. So thank you for your attention.
Thanks a lot, Alexandra. Now we have Pierluigi Antignani online. Pierluigi, do you hear us?
Yes, I am here.
Welcome.
Thank you, Alexandra, for your very complete presentation as usual.
Thank you.
My question is this: there are some specific diagnostic patterns to decide what is the better treatment of this pelvic varicose vein, or you use only a clinical evaluation?
If you are talking about pelvic origin varicose veins in leg and vulvar varicose veins, I always do. Even if I don't want to treat the pelvic veins, I always perform ultrasonography. First of all, I'm a vascular surgeon and a gynecologist, so I have two specialties. So I always perform transvaginal ultrasonography and also transabdominal ultrasonography to find if there is where there is a reflex, if there is incompetency of the ovarian vein, or if there is obstruction. But even if I find something and the patient do not have any pelvic symptoms, or you know, he doesn't have any renal symptoms, hematuria or whatever, I do not treat pelvic veins if I have, even if I find something. You have to remember that in many cases, as I told you before, 90% of patients that are asymptomatic patients, so I usually start the procedure from below if I have the pelvic origin varicose veins.
Thank you. Thank you very much.
Александра, спасибо. Спасибо, Пьер-Луиджи. У нас есть еще один короткий вопрос из Москвы. Сергей Передко на связи. Сергей.
Да. Добрый вечер, Александра. Спасибо. Прекрасное сообщение. Вопрос единственный. Все представленные случаи – это пациенты с тазовым полнокровием. Но одной из причин тазового полнокровия бывает надкрекер-синдром. Что вы делаете таким пациентам?
I think I might understand you. You wanted to me what should I do if I had a nutcracker syndrome, so left renal vein compression, in that case, of varicose veins of pelvic origin.
Hypertension. Почечной флебогипертензией.
What was, I didn't understand that.
With left renal hypertension. Yes?
Oh, with left renal hypertension. Okay, if you are quite sure that it's left renal compression with the hypertension, I think that transposition is the best option. It's surgical transposition. I usually recommend.
Okay, thank you.
Спасибо. Спасибо большое. Спасибо, Сергей. Спасибо еще раз, Александра. Уважаемые коллеги, мы полностью закончили нашу программу. Она получилась насыщенной, очень интересной. Вы видите, коллеги со всех уголков мира с прекрасными презентациями. Поэтому я бы хотел пригласить еще раз Виктора Канату, Лауэлла Кабника и Курсата подвести итоги и сказать два слова в заключении. Пожалуйста, коллеги. Лауэлл.
On behalf of Vein and Lymphatic University, I'd like to thank all of the speakers and all of the comments furthering and enhancing patient care. This has been a tremendous session, and I could go on forever wrapping up, but I just wanted to say thank you for allowing us to participate in the St. Petersburg Venous Forum.
Thank you for the kind invitation.
Виктор. Where is Victor? Курсат.
He's always busy. Next year, definitely, we want all of you on board, face to face, in this wonderful city again. And possibly...
Yes, I'm here.
Oh.
Спасибо. Спасибо всем. Так, где Виктор?
Victor is there. Thank you, Jorge. Victor, are you there?
Yeah, I'm here. The problem is somebody stopped my video. Okay, so far so good. Thanks for everything. We are very happy to just have all the people all over the world in this great St. Petersburg meeting, and we will see it again in the next session in the near future. Hoping we'll be live already and we'll be together. And again, thanks all my friends all over the world. And I will just say that DLU will always work together to embrace and help friendship, teaching, and outcome for the patient. Thank you very much.
Спасибо. Спасибо всем.
Happy and healthy New Year.